Hello everyone, today we're going to talk about radiographic distortion. Distortion is the second of the two geometric properties affecting radiographic image quality, the other being detail. The misrepresentation of the size, which is magnification, or the shape, which is either elongation or foreshortening, of the structures being examined. Just like we learned when detail was studied, there can be distortion of the anatomical structures, even though it may not be seen due to poor visibility, meaning the wrong technique was utilized. When the image is being acquired, meaning the part is actually being radiographed, only magnification is possible because of the divergent nature of the beam. Magnification and minification of the anatomical part radiographically are possible as post-processing features when using digital software. Magnification is controlled by both SID and OID changes. Magnification occurs when SID decreases from its suggested number of inches, usually 40 or 72. And we can say that as SID increases, magnification decreases. Think of a PHS. The required SID is 72 inches. Why do we do that? To reduce the magnification of the heart shadow. As SID decreases, magnification increases. And of course, any time that you magnify, you lose detail. Important fact, magnification during the acquisition phase of the image is not desired. Remember, as I just said, magnification is a loss of detail. You lose resolution when you magnify. Regarding OID, the general rule in radiography is to always get the part of interest closest to the IR. Why do we do this? As OID decreases, magnification decreases, and resolution or detail increases. OID and patient positioning. Magnification is controlled by positioning the body part and the tube to maximize SID and minimize OID. For example, with an IVP examination, this of course is an examination done for the kidneys. The patient is supine or placed supine on the table. Why? To bring the kidneys, to place the kidneys closer to the IR. Remember, your kidneys are more posterior retroperitoneal structures. So if we lie the patient supine, kidneys are closer to the IR, we get less magnification, better detail. Lateral cervical spine. Well, when you position for a lateral cervical spine, the shoulder is against the IR, leaving you a lot of OID between the cervical spine and the IR. Therefore, to compensate, instead of using 40 inches, bring that SID back to 72 inches. There is a way to calculate for size distortion. Magnification can be assessed by calculation of the magnification factor, which is known as M. So to calculate the magnification of the image, you take the SID and you divide it by the SOD. Sometimes you hear the term magnification is SID over SOD, SID over SOD. Typical question might be if the SID is 40 inches and the SOD is 35 inches, what's the magnification factor? So the answer would be SID over SOD, 40 over 35. giving you an answer of 1.14. What does that mean? It means that the projected image of a given anatomical part in the body is 1.14 times larger radiographically. So, as an example, if the tumor in the body measures 2 centimeters, then the projected image of the tumor is 2 times 1.14, that's 2.28 centimeters. So in the body, the tumor is 2 centimeters. Radiographically projected, it's going to be at 2.28 centimeters, a little bit larger because, of course, there's always magnification. If the SID is 50 and the OID is 2, what's the magnification factor? Well, remember, it's SID over SOD, and here we don't have the SOD being given. So the SID is given as 50 inches, the SOD isn't, but remember SID equals SOD plus OID. So to calculate for the SOD, you take the 50 inches minus the 2 inches, giving you 48. The magnification factor now is 50 over 48, or 1.04. Here's a question. If the projected image of the calcification in the body measures 7.25 centimeters and the magnification is 1.03, what is the size of the actual object? So we can reverse the formula a little bit. We can say O equals now I over M. So if I take 7.25 and I divide it by 1.03, so I'm taking the image size over the magnification factor. The actual size of the calcification, the size of the object in the body, is 7.04 centimeters. So you would take the image size, I, you would divide it by the magnification factor, M, to obtain the size of the object in the body. So in this case, once again, the image size was 7.25 centimeters. The magnification factor was 1.03. You divide through. And the actual size of the calcification in the body, once again, it's going to be a little bit smaller because it's the actual part, what's projected, it's going to be a bit larger. So the actual size is 7.04 centimeters. Factors affecting shape distortion. Shape distortion occurs due to the unequal magnification of the actual shape of the structure being examined. What does it mean when we say elongation? Elongation, it stretches the object so that it appears longer than it truly is. How do you get this? You get it mainly when the tube or the IR is improperly aligned. It causes or changes, and tube angulation can also cause this elongation, but as we mentioned, never foreshorten. So if the tube and the IR are not properly aligned with one another, or if you angle the tube against the part, you're going to get elongation. Foreshortening, it's the opposite of elongation. Foreshortening projects the object so that it appears to be shorter than it truly is, and this only occurs when the part is improperly aligned. As far as alignment is concerned, to avoid shape distortion, there must be careful alignment of the central ray with the anatomical part and the image receptor. The central ray must be at a right angle to the anatomical part and to the IR. The part and the IR must be parallel. As far as the central ray is concerned, any structure that is not positioned at the central ray will be distorted because of the divergence of the beam. If you take a look at this object here, you can see how the shadows would be cast if the central ray was coming down perpendicular, versus now if you take the object, you put it in the more divergent beam, take a look at the shadow, and you can see the distortion. Anatomical part elongation occurs when there is poor alignment of the tube and or the IR, and foreshortening occurs when there is poor alignment of the part. So elongation, poor alignment of either the tube and or the IR, foreshortening, poor alignment of the part. Because the kidneys lie in an oblique angle within the body of 40 degrees, to get the individual kidney parallel to the IR, the technologist would perform oblique projections at 40 degrees. We'll learn this when we talk about IVPs, but if you were to take your hands and you were to place them on your abdomen, the angle that your hands are at approximates the angle of the kidneys in your body. So if I imagine that I'm lying down and I turn myself RPO, look at the angle of your hand. Okay, imagine you're laying down on something. That left kidney then would be parallel. If I lie back on my back and now I rotate LPO, I look at the angle of my hand, which represents the kidney, and I can see now that that's parallel to the image receptor. When we talk about the image receptor, if the IR plane is not parallel to the object, or if the central ray is not centered to the part, shape distortion results exactly as if the object was not parallel. Angulation is generally used to avoid superimposition of body parts. So if we take three different shapes that might represent different parts of a anatomical organ, for example, one right on top of the other. If I were to use a perpendicular beam, what I would have is I'd have that brown oval shape with the star superimposed with the rectangle superimposed. So I would get a lot of superimposition. If I angle, however, if I angle and I hit that brown oval, I'm going to have it appear on my image receptor here. If I hit the star with an angle, I'm going to now have it next to the brown oval. And if I hit the rectangle, I'm going to have it next to the star. So now three structures that were superimposed if I used a perpendicular beam are now going to be separated. They will be stretched out a bit because I'm using an angulation, but they will be separated. As far as the direction of the central ray, the most common angulation is longitudinal, and of course you're either going to angle toward the feet in a caudal direction or toward the head cephalidly. Very important fact, we want to always remember this as radiographers. If the patient position is reversed, the tube angle must be reversed to maintain the correct relationship. So if you were doing person AP, whatever you were doing body-wise, body part-wise, it recalled for an AP at a 30-degree cephalid angle. If I couldn't have them AP for some reason and they had to be PA, well, now what would I do? I'd keep that 30 degrees, but I would reverse the angle to use now a 30-degree caudal angulation. I stress to you to make sure that you look at your book, look at all of the diagrams that are in the chapter for distortion. Carlton gives some very, very good diagrams showing you distortion and how it occurs. So I'd like to thank Carlton and Adler for being able to use and reference their material in this PowerPoint.